It's time for another warm-up. Let's get going. Which genetic syndrome is caused by each of the following underlying mechanisms? So first we have absence of the HGPRTase, that's Lesch-Nyhan syndrome. Deficiency of aldolase B, that's going to be fructose intolerance. Deficiency of cystathionine synthase, that's going to be homocystinuria. Galactose 1-phosphate uridyl transferase deficiency, resulting in intellectual disability, hepatosplenomegaly, and cataracts. That's going to be galactosemia. Next, we have deficiency of tyrosinase. That's going to be albinism. Next question. What is Potter sequence? So this is where you have a bilateral renal agenesis because there is a malformation of the ureteric bud. That causes oligohydramnios because the fetus is not making urine, and that causes a lot of problems as well, like limb deformities, facial deformities, and pulmonary hypoplasia. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to discuss some basic concepts related to red blood cells. We've already talked about the physiology of hemoglobin and the oxygen-carrying capacity of red cells, but now we're talking more about some terminology used to describe red cells and the various abnormal shapes that red cells can take on in various disease states. So the formal scientific-sounding name for red cells is erythrocytes. They're anucleate, so they've lost their nucleus, and they're biconcave, so that they have a large surface area, which helps facilitate gas exchange. They're also very flexible, which is important because they have to be able to squeeze through those narrow capillaries. And the main molecule that's responsible for the biconcavity and the flexibility is a cytoskeletal protein called spectrin. So make sure you're familiar with that name. So anytime you lose that classic biconcave shape, like with sickle cell disease or with hereditary spherocytosis, the blood becomes more viscous, which can lead to sludging in the capillaries because the red blood cells are taking the wrong shape. Now, we've mentioned a few times already that red cells rely on glucose for their energy. Even in the fasting state, your red cells still need glucose. 90% of that glucose is anaerobically metabolized to lactate, and 10% is metabolized by the HMP shunt. And we mentioned that if you have a deficiency of pyruvate kinase, which is an enzyme in the glycolysis pathway, that's going to cause a problem getting energy to the red blood cells, and the red cells will hemolyze. We'll see that again when we talk about causes of hemolytic anemia. You should also know that the average lifespan of a normal, healthy, mature red cell is about 120 days. That's potentially testable. You also need to be familiar with the special vocabulary used to describe red cells. So if a pathologist looks at a peripheral smear and says there's anisocytosis, what does that mean? Anisocytosis means you have red cells of varying sizes. So iso means same. So anisocytosis means the cells are not all the same size, which is abnormal. Or the pathologist might report that there's poikilocytosis. Poikilocytosis means you have cells of varying shapes. We'll get to all those weird shapes in a second. If you have too many red cells, that might be called polycythemia, or it could be called erythrocytosis, two terms for the same thing. And the immature red cells are called reticulocytes. So when your bone marrow is busy churning out new blood cells, you're going to see more and more of those immature forms on the smear, and that's called reticulocytosis. But here's some good news. You don't really need to worry about remembering all the different stages of different red cell precursors. Let's talk about some more things that the lab might report on a peripheral blood smear. Various types of pathological red cells. So these are definitely high yield for you to know, and I'd be very surprised if you didn't have at least one question on one of these. Let's start with basophilic stippling. These are little purple basophilic dots all over the cell, which are thought to be clumps of denatured RNA within the red cell, or possibly ribosomes that clump together. The main disease state I want you to associate with basophilic stippling is lead poisoning. Now, there are other things that might cause basophilic stippling, such as thalassemias, anemia of chronic disease, and alcohol abuse. But I want you to remember lead poisoning as the main cause of basophilic stippling. There's a cell called an echinocyte, or a Burr cell, which has regular, uniform spikes all over its surface. So remember, regular spikes. So Burr cells are seen in uremia or renal failure, and they can also sometimes be seen in pyruvate kinase deficiency. And there's a similar looking cell called a spur cell, or the proper term for this is an acanthocyte. These cells are also spiky, but they are irregularly spiked. So the spacing of the spikes is irregular, and the size of the spikes is irregular. Some are big, some are little. Acanthocytes are seen in liver disease and A-beta lipoproteinemia. Spherocytes are red cells that lose their biconcave shape, so they become spherical. And the classic condition where you see these is called hereditary spherocytosis. Schistocytes are fragmented red blood cells, leftover pieces of red cells that have been chopped up. So imagine you have DIC or TTP-HUS, where you have pathologic intravascular clotting and a huge network of fibrin strands inside the blood vessels. And red cells are being forced through that fibrin mesh. So the cells get snagged on the fibrin, or a slice of the cell just gets sheared off. So again, a schistocyte is a fragmented red blood cell. Then the next one is target cells, which are really easy to identify because they look like a bullseye or a target. And they're much easier to identify than Walmart cells or JCPenney cells. There are a couple of different mnemonics to help you remember the diseases that cause target cells, but I like the mnemonic THAL, T-H-A-L, because that helps you remember that thalassemia is one of them, the H is for hemoglobin C disease, the A is for asplenia, and the L is for liver disease. So with liver disease, you can see target cells, and then what other pathologic form did we just say you could see with liver disease? Acanthocytes, or spur cells. Now here you see sickle cells, which are sickle-shaped or crescent-shaped. And obviously we see these in sickle cell anemia. And then a Howell-Jolly body is the basophilic remnant of a nucleus in a red cell, which we see in patients with asplenia, no spleen. Maybe they had trauma to their spleen and it ruptured and they had to have it surgically removed. Or sometimes patients with immune thrombocytopenia will have their spleen removed surgically to treat the ITP. Patients with sickle cell disease will infarct their spleens over and over through the years until basically there's no functioning spleen tissue left. But any of these patients with asplenia for any reason could potentially have Howell-Jolly bodies in their red cells. A similar looking finding is called Heinz bodies. So Heinz bodies are these little clumps of denatured hemoglobin which shouldn't be there. And as these red cells pass through the spleen, the splenic macrophages just bite the Heinz bodies right out of the cell. And that leaves something called a bite cell. Now think back. When did we mention bite cells and Heinz bodies and oxidative damage to red cells before? G6PD deficiency, remember? Patients with G6PD deficiency are sensitive to certain drugs that cause oxidative damage, like sulfonamides and dapsone, and also favabeans. That's a classic one. Now, do you remember the mnemonic? It was spleen purges nasty inclusions from damaged cells, which stands for sulfonamides, primaquine, nitrofurantoin, isoniazid, favabeans, dapsone, and chloroquine. So make sure you know those. We talked about this back in biochemistry when we talked about the hexose monophosphate shunt. So patients with G6PD deficiency can't go through the HMP shunt, so they can't generate reduced glutathione, so their hemoglobin gets oxidized and it forms Heinz bodies. And then the splenic macrophages remove the Heinz bodies and that results in bite cells. And one other thing, it might be tricky to tell a Heinz body from a Howell-Jolly body, but a Howell-Jolly body is a remnant of the nucleus. So a red cell might have many Heinz bodies, but it can only have one Howell-Jolly body per cell. So for Heinz bodies, think about Heinz 57 steak sauce. 57 is a big number, so you can potentially have lots of Heinz bodies in a cell. There are teardrop cells, which are shaped like teardrops, and they're seen with myelofibrosis. You can also see elliptical-shaped red cells, which are called elliptocytes, and these are seen in something called hereditary elliptocytosis. Sometimes you may hear these called pencil cells or cigar cells. And finally, I want to discuss sideroblasts and ring sideroblasts for just a second because this is potentially confusing and it gets mixed up a lot. So first of all, what is a sideroblast? A sideroblast is a nucleated red cell precursor that has granules of iron in the mitochondria. And sideroblasts are found in the bone marrow of normal, healthy people. So sideroblasts are perfectly normal. They're not pathological. And again, they're found in the bone marrow, not in the peripheral blood. However, if you have a disorder that affects heme synthesis, the sideroblast can't use all the iron that's stored in those iron granules. So they have too many granules, and the iron granules sort of surround and encircle the nucleus. So they form a ring around the nucleus. Now we call this a ringed sideroblast. So sideroblasts are normal, but ringed sideroblasts are abnormal. And where do you find these ringed sideroblasts? Again, they're found in the bone marrow. Not the peripheral blood, but the bone marrow. Now, patients with disorders of heme synthesis are going to be anemic, and when you do a bone marrow biopsy, you're going to see large numbers of these abnormal ringed sideroblasts. So these diseases are said to cause sideroblastic anemia. Now, lots of different things can cause sideroblastic anemia. Certain genetic conditions, certain drugs, chronic alcohol use, and myelodysplastic syndromes. So sideroblastic anemia isn't a diagnosis in and of itself. It's a sign of some other underlying disease. Now, you may sometimes see lead poisoning listed as a cause of sideroblastic anemia, but that's not really well documented. We're going to talk about lead poisoning in the next video. Now, before we move on, let's do a quick whiteboard review to help make sure you have all these terms really locked down. For this whiteboard review, we're going to match these terms on the left, written in blue, with the definitions written in green on the right. So the first term is an acanthocyte, and that's another name for a spur cell, those red cells with irregular spikes. What diseases do we say we saw the acanthocytes or spur cells? In liver disease and in A-beta lipoproteinemia. Now the next one is degmacyte, and I'm kind of sneaking this one in because a degmacyte is another name for a bite cell. Next we have echinocyte, and echinocytes are those cells with the regular uniform spikes. We said the other name for those were the Burr cells. The next one is erythrocyte, which is just a normal name for a normal red cell. Then Heinz bodies. Heinz bodies are those oxidated hemoglobin bodies that are found in the red cells, precipitated out in the red cells in patients with G6PD deficiency. Then a Howell-Jolly body is the nuclear remnant that are found in red cells in patients with asplenia. Then a reticulocyte is a name for an immature red cell. A schistocyte is a fragmented red cell that we see in patients with DIC and other forms of microangiopathic hemolytic anemia. And then a spherocyte is obviously a spherical red blood cell. So good job with those. Next, I want to talk about a couple of topics related to blood transfusions. So first of all, there are several different types of blood products that you might be transfusing. The most common blood product to transfuse is packed red blood cells, or PRBCs. These are red blood cells that have been separated from the other donor blood components. So it's concentrated red blood cells, which we usually give to patients that have significant anemia, especially from acute blood loss, from trauma, or maybe a GI hemorrhage, or maybe from surgery. And you can kind of reason out why we would give red cells. Patients with anemia have decreased hemoglobin, so we want to increase the oxygen carrying capacity. We transfuse platelets for certain types of thrombocytopenia, especially if there's active bleeding due to thrombocytopenia, or if a thrombocytopenic patient needs to have surgery and you're worried about post-op bleeding. Or possibly you might give platelets to a patient whose platelet count is normal, but the platelets themselves are defective, so that the patient can't stop bleeding. Sometimes we transfuse fresh frozen plasma, or FFP, which is plasma from which the red cells and other cellular components have been removed. So it's basically serum, the water and electrolyte portion of the blood, plus the plasma proteins and the clotting factors. Now, FFP is sometimes given to patients with a clotting factor deficiency, like in a patient with cirrhosis whose liver isn't making clotting factors, or in disorders like DIC, or thrombotic thrombocytopenic purpura, or TTP. Both of these are disorders in which there's widespread intravascular coagulation and all the clotting factors are being consumed. But the idea here is to give FFP to replace the coagulation factors that are missing. Now there's a similar blood product that we give to patients with a warfarin overdose who are bleeding and who we need to rapidly reverse that anticoagulation. Remember what that blood product was? It's called prothrombin complex concentrate, or PCC, which is basically an infusion of the vitamin K-dependent coagulation factors, which are factors 10, 9, 7, and 2. Then one more blood product you might transfuse is called cryoprecipitate. This is similar to FFP or PCC, but you basically thaw the FFP and you collect just the clotting factors, especially fibrinogen and factor VIII, and also some von Willebrand factor. So you can use it for patients with DIC or TTP because these patients are consuming all their fibrinogen. So you can give cryoprecipitate just like you would FFP. Or you might give it to a patient with hemophilia A where you wanted to give factor VIII. But overall, we don't use cryoprecipitate much anymore. It's more common to give specific clotting factors that have been pooled from multiple donors. So if you have a patient with factor VIII deficiency, you just give pooled factor VIII rather than cryo. And just to mention briefly, the risks involved with giving transfusions include things like iron overload. So you have a patient who receives a ton of packed red cells. If they weren't iron deficient, they could end up with too much iron, and they can get hemochromatosis from that. They could develop some hypocalcemia because red cells are stored with sodium citrate to prevent coagulation of the blood. And when that citrate gets transfused, that citrate can bind to all the patient's calcium, and that can lead to hypocalcemia. The patient could develop hyperkalemia if the red cells have been sitting in storage long enough that some of the older red cells have started to lyse, and the intracellular potassium spills out into the transfused fluid. And there's a very small risk of infection because we screen blood donors for all sorts of infectious things like HIV and viral hepatitis and so on. And of course, there's a risk of transfusion reactions, which are discussed in the immunology videos. And speaking of transfusion reactions, make sure you review the blood types, or ABO blood groups. Now, you probably learned everything you need to know about ABO blood types back in high school biology. I don't really have much to add that you probably don't already know about that. So you can review those on your own if you need to. But two quick things I do want to point out. First of all, what happens if you transfuse an incompatible blood type? Well, you're going to get an antibody-mediated type 2 hypersensitivity, right? Circulating antibodies bind to the cellular antigens, and that leads to hemolysis, fever, possibly shock, kidney failure, and death. And then what's the number one cause of transfusion reactions? It's clerical error. Somebody goofed on the type and cross, or somebody mislabeled the blood, or it got delivered to the wrong floor or whatever. So you're going to see the nursing staff going through this huge checklist, checking the patient's ID bracelet, checking the labeling on the blood products, being extra cautious. Because these transfusion reactions can be really dangerous, but they're pretty much totally preventable. There's one disorder related to blood type incompatibility that you should know something about, which is erythroblastosis fetalis. And that's specifically due to Rh incompatibility. So take a look in the study guide. Erythroblastosis fetalis occurs due to maternal antibodies against fetal red cell antigens, typically antibodies to Rhd. So Rh negative moms who don't have that Rhd antigen on the surface of their red cells do not naturally have antibodies to Rhd. It's only after mom is exposed to Rhd antigens on the Rh positive baby's red cells that mom starts developing antibodies. So this exposure may occur during the first pregnancy with an Rh positive baby, but these antibodies don't cause problems during that first pregnancy. The antibodies only develop in a quantity abundant enough to cause problems in subsequent pregnancies. So if there's any trauma or something where the baby's blood comes into contact with the mother's blood, which could include delivery, so if the baby's blood comes into contact with mom's blood during that first pregnancy, mom's immune system becomes sensitized to the Rhd antigens, and mom starts making anti-Rhd antibodies. Then, on subsequent pregnancies, if the baby is Rh positive, the mom's anti-Rhd IgG antibodies can cross the placenta and attack the fetus's red cells. So the clinical features of a neonate with erythroblastosis fetalis include anemia due to hemolysis of those fetal red cells, and then those cells hemolyze, hemoglobin is going to be released, and that hemoglobin is converted into bilirubin, and the bilirubin causes jaundice and possibly kernicterus in the neonate. The fetus can also develop hydrops fetalis, which is a generalized fetal edema. And be aware that erythroblastosis fetalis is life-threatening, and it can cause intrauterine death. So what do we do to prevent all this? Well, we give Rh-negative moms anti-Rhd immunoglobulin at 28 weeks, or whenever there's any type of trauma, like a motor vehicle accident, or anytime there's an abortion or miscarriage, and also within 3 days of delivery. Basically, anytime the mom might be exposed to the fetal red blood cells, you're going to give anti-Rhd immunoglobulin, which is IgG, to sort of hide those fetal red blood cells so that the mom's immune system never sees them. Once the mom's immune system starts seeing those fetal Rhd antigens, she's going to develop an immune response to them. So we hide the Rhd positive fetal red cells by giving anti-Rhd immunoglobulin so that mom never develops that immune response. So again, the scenarios where the mom's immune system is likely to see those red blood cells would be after 28 weeks, because you're more likely to deliver after 28 weeks, and at any traumatic event where you might have mixing of blood crossing the placenta, and also within the first 3 days of delivery. So now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video, and we'll go over the answers together. First question, what allows red cells to change shape as they pass through vessels? That's the protein spectrin. Next, what name is given to immature erythrocytes in circulation? We call them reticulocytes. Next one, what pathologic form of red cell would you see in the following diseases? So with lead poisoning, you see red cells with basophilic stippling. With G6PD deficiency, you might see bite cells and also Heinz bodies within the red cells. With DIC, you're going to see schistocytes. With A-beta lipoproteinemia, you're going to see acanthocytes, which are also called spur cells. And with asplenia, you might see Howell-Jolly bodies and also possibly target cells. And that's it for now. I'll see you next time.